Here's our rapid-fire roadmap for today. We'll hit the Parks classification, management strategies, a key clinical pearl, a classic exam trap, and then we'll wrap it all up with the quick recall test. Section 1. The Parks classification. To master this classification, you have to understand the foundational anatomy. The entire system is based on how the fistula tract physically relates to the internal and external anal sphincters. Let's break down how these tracts actually move. Type 1 is intersphincteric, meaning the tract runs directly between the internal and external sphincters. Type 2 is transsphincteric, where it actively crosses through the external sphincter. Type 3 is suprasphincteric. This one travels high up, above the external sphincter before descending. And finally, type 4 is extrasphincteric, passing completely outside the entire sphincter complex to enter directly into the rectum. Visually, just think of this disease process as leveling up in complexity. It's stepping progressively further outward from that initial intersphincteric space. You start right in the middle, between the sphincters. That's your type 1. As it gets worse, it pushes outward. It crosses the external muscle for type 2. It pushes up and over for type 3. And at its absolute most severe, it completely bypasses the entire sphincter complex on the outside for type 4. If you visualize that outward and upward expansion, it's pretty much impossible to forget. Moving right along to Section 2, Management Strategies. Understanding that anatomy directly unlocks how we surgically manage these fistula. You really can't memorize the surgeries without knowing the anatomy first. There's a massive difference in how we approach these extremes. For a simple, low, type 1 tract, a straightforward fistulotomy is commonly appropriate. It's usually the simplest to deal with. But a type 4, that is a whole different beast. It requires highly complex surgical management. Because it totally bypasses the sphincters, you're often dealing with severe systemic pathology. We're talking serious underlying causes here. Things like Crohn's disease, malignancy, trauma, or profound pelvic sepsis. So what about the middle ground? Your type 2 and type 3 tracts? Well, management here entirely depends on how much of the external sphincter is involved. If it's a low tract, sure, a fistulotomy might still be on the table. But if it's a high tract passing through or above a massive chunk of muscle, you absolutely must avoid dividing significant portions of that external sphincter. Instead, you'll need to reach for sphincter-preserving procedures. Things like placing a seton to allow controlled drainage without immediately cutting the muscle, doing a lift procedure, or creating an advancement flap. Section 3, our key clinical pearl. Listen closely because this is the absolute core of surgical decision-making for this topic. This is your golden rule. The more external sphincter involved, the greater the risk of fecal incontinence with a fistulotomy. That is exactly why we care so much about the Parks classification. A simple low fistula, fistulotomy works great, but a complex or high fistula mandates sphincter preservation. Cutting through too much muscle during a fistulotomy will literally result in a disastrous functional outcome for your patient, and nobody wants that. And just tuck this little fact away for the wards. Type 1, that intersphincteric fistula, is the most common one you're actually going to see. Out of all those complex pathways, the simplest one passing directly between the internal and external sphincters shows up the most frequently. Section 4, the classic exam trap. Examiners absolutely love to trip-stress students up with this one. Do not mix these two up on test day. You're going to see questions deliberately trying to blur the lines between the Parks classification and Goodsall's rule. Here is the distinction. The Parks classification solely describes the anatomical relationship of the fistula tract to the anal sphincters. Period. Goodsall's rule, on the flip side, is a predictive mapping rule. It predicts where the internal opening is located based entirely on the position of the external opening on the skin. One is pure anatomy, the other is predictive mapping. Keep them totally separate in your head. Here's another sneaky trap to watch out for. An extrasphincteric fistula, R type 4, is entirely its own entity. It passes completely outside the entire sphincter complex and enters the rectum. Please do not let a multiple choice question convince you that an extrasphincteric fistula is just a really high transsphincteric fistula. It is not. It has a completely different anatomical pathway that bypasses the sphincters entirely. Finally, Section 5, quick recall test. All right, let's see if this explainer did its job. Listen to this scenario carefully. A fistula tract passes between the internal and external anal sphincters without crossing the external sphincter. Focus on those spatial keywords. What is the Parks classification? Take a second. Lock in your answer. If you guessed type 1, the intersphincteric fistula, you nailed it. It's right there between the sphincters, making it the most straightforward and most common type.
To make sure you never lose points on this, just burn this 4-word memory sequence into your brain. Inter, trans, supra, extra. Say it a few times. It maps perfectly to types 1, 2, 3, and 4, stepping outward from between the sphincters, across them, above them, and then completely outside them.
Keep that sequence in your back pocket, and you will never fear a fistula question again. From simple fistulotomies to complex sphincter-preserving setons, you've now got the visual and anatomical blueprint. So the next time you're down in the ER staring down a perineal abscess, ask yourself, what hidden pathway is it taking, and is your patient's continence at risk? Thanks for hanging out with me for this explainer, and I'll catch you in the next one.